to keep us on task and get you guys out of your original time, because I see it's snowing. Okay, so let's just brief a little bit about Saturday. For those that are coming, please know there is gonna be a group here just doing some, they'll have like camera stuff in the corner, probably less than an hour, they just want some clips of, like you guys, so just ignore them. There'll be like a reality show, I guess. They're here, but just pretend they're not here, just do what you do. I know, I gotta get my hair done, so I got some work to do. But they're here, and I know I said this, they're doing a story on rural EMS. So the plan for Saturday is this is gonna be another practical. We're gonna have an airway mannequin set up. We'll do station rotations again, but we'll go back over everything from bag valve, nasal airway, oral airway, eye gel airway. More patient assessment, more med administration, injections, mixing up meds, and just vital sign taking. So we're just gonna kind of reinforce those concepts a little bit more. Tonight, we're gonna try to take another big bite out of the medical emergencies unit. Medical emergencies is kind of it's probably the most like didactic portion, because we're learning about medical conditions that a lot of you have at the EMR level should have very little to no knowledge, and that's okay. So we're trying to scratch the surface on that stuff. Your textbooks, there's a lot of chapters in medical emergencies that don't necessarily pertain to the EMR level, but we will go through them and touch on the high points of it. The big ones for the EMR level are your respiratory, which we did on Saturday, and cardiovascular, which we're going to start with first. So just to kind of recap on the respiratory emergencies. So chief complaint is going to be, I can't breathe, difficulty breathing. We talked about that respiratory distress versus respiratory failure, correct? So that failure, when they're at that point, they're no longer really able to interact with you. Their mental status is deteriorated, where all they're focused on is where their next breath is coming from. That's that tipping point from respiratory distress to failure. They're beginning to shut down, and I would say respiratory, if not cardiac arrest, is imminent. So we just be prepared to do what we have to do. Otherwise, the chief complaint are, the assessment is still a real kind of rapid head to toe, which may just be visual, looking to make sure no obvious life threats. We make sure their airway is patent, meaning we have a process for air, or a route for air, that there's not an airway obstruction, they don't need to be suctioned. They're breathing, so are they breathing fast, slow? And at that, the big thing we're trying to answer there is, do we need to assist their breathing with the bag valve mask, or can we use supplemental oxygen? So usually the difficulty breathing complaint, we're doing something. So whether it's usually going to be some like oxygen administration, getting ready to move to a nebulizer medication, but trouble breathing, we're not able to get a SAT, just put them on oxygen. Then we can move into kind of the head to toe and patient assessment. There's things that I'm going to briefly look at that may be pertinent to respiratory distress. That can include, do they have really distended neck veins? Their trachea should be midline, and we're going to talk about assessing for tracheal tugging during the trauma unit. But, well, I'll just touch on it now, and I think I talked about this before. So your sternal notch, if you feel where your collarbones come together, there's a little dip at the very top of your breastbone. So it's called your sternal notch. Now you're gonna, if this is my breastbone here, I'm gonna kind of take my fingers, go up and over to grab their trachea. It's really uncomfortable if I come up and I did that to you. Uncomfortable to the point of some really mild, something painful. But I'm going to reach around, kind of grab that trachea, and as they breathe, so if you do it to yourself, when you breathe, that trachea should be rigid. It's not moving, right? If you can feel your trachea moving right or left when you breathe, let me know right now. All right, so we're breathing, it's staying consistent. Now, when they start to, if we notice when they're breathing and we feel this little, where we can feel that trachea starting to tug, that's suggestive of a possible pneumothorax or some air building up in their chest. Anyone who's been an EMT or past EMTs, they might teach tracheal deviation. You see tracheal deviation in autopsies. That if the trachea is deviated to the point it's visually displaced, they're dead. That's not something that you see a deviated trachea and they're talking to. So that means to deviate, to shift that trachea, means that person has built up enough air in that collapsed lung that has completely displaced the heart and the lung to the opposite side of the body, thus pulling that trachea over. So it's a super, super late sign. In my years, I've never seen a deviated trachea on a person who's alive, but I have noticed that before we have to do treatment for that pneumothorax, you can just slightly feel that trachea starting to tug. And that will usually be in combination with distended neck veins, because that pressure on the heart isn't allowing the heart to pump blood out, it's backing up in the neck vein. So super rare findings, but that's an example of a pertinent physical assessment to someone who's having trouble breathing. Otherwise, I like to inspect the chest. For example, you lift up someone's chest wall, they got a big bruise right there. Okay, it's you know, they're probably having trouble breathing secondary to a chest wall injury. That, you know, we have to consider the presence of trauma. Not much to look at the belly, the hips, the extremities, with the exception of I still like to look at the lower ankles on everyone to see if there's water, edema, pedal edema we call it. So ankles that are swollen, and who's seen swollen ankles? And when you can get pedal edema in the lower extremities to the point that if I push it in and I let my hand go, it stays indented. And we call that pitting edema. And it's also highly suggestive of heart failure. So, and that edema happens just because the heart's not getting blood pumped out, so we're getting back pressure, like in the capillaries pushing water out. So it's the same thing that happens in the lungs. So it's a relatively quick assessment, baseline set of vitals. We're kind of initiating oxygen therapy. We're still going to ask, try to do our OPQ and ST as it relates to the breathing. You know, what were you doing when it started? How bad is it? Has this ever happened before? And with your sample, are you under treatment for asthma, emphysema, things like that? Anytime you suspect a restrictive airway problem, so any of your COPDs, be it asthma, emphysema, pneumonia, a good therapy for an EMR to initiate is just 2.5 to 5 milligrams nebulized albuterol. That there's very, very few contraindications. So we get all that stuff and we start to work the way up to administer the medication. And then if we're to the point, we just administer the albuterol until EMS arrives. Lung sounds, we can assess them. But remember, we're not asking you to be able to differentiate between an emphysema and asthma, pneumonia. We just need to know breath sounds sound wheezy, they sound wet, they're there, they're not there, some really kind of basic stuff. Does that make sense? Any questions about the respiratory stuff we talked about? Okay. I did send out the handbooks for the ones we did Saturday, and I think a couple for today. The handbooks of medical emergencies for EMTs are a lot more robust than what you need. Please remember that those handbooks, if you just carve out an hour, sit down, you go through them, you check your answers, and then please, if there's a concept you're looking at going, this isn't making sense, I don't understand why I put that on, that's what you bring back to class, and then we kind of talk about it. So, anything from the handbooks you've done so far that you need to touch on? Okay, we'll jump into cardiac, probably my least favorite unit.
You guys, if he starts talking over your head, just tell him to stop.
Katie, shush. All right. So cardiac emergencies, these are the reason respiratory and cardiac tend to be kind of bigger units. These are the type of complaints where people call 911. Chest pain, can't breathe. Those are typically more emergent nature, where people are less prone to get in the car or make an appointment that when it happens, they typically need help right now. So it's a large percentage of calls we see, relatively high acuity risk, I think is a good word, meaning if you're having a heart attack, it's not gonna get better on its own. So to recognize the symptoms and initiate treatment, the better the outcome. Heart disease it is classified as the #1 killer. I think we have to be a little bit careful of that. These statistics are generally pulled from death certificates, and I do urge caution that majority of deaths in people, a lot of the coroners, MEs, myself included when I did it, atherosclerotic cardiovascular disease tends to be #1 on a large percentage, where it's just an umbrella term. It's a natural death. We've kind of ruled everything else out. Something to do with the heart, blood vessels, clot, atherosclerotic cardiovascular disease, umbrella. But that gets sent up as a statistic of heart disease being the #1 leading cause of death. So I think it's very important to know that a large percentage, but I think it's kind of inaccurately reflected. So we'll go back over a little bit of the A&P, the pump, the container, and the fluid, or the heart vessels and blood. The electrical makeup of the heart. So when we did A&P, we had talked about the heart being essentially an electrical pump. Within that heart, to break it down, there's essentially two types of cells. There's cardiac cells that have the ability to contract, and there's pacemaker cells, which their primary function is to generate and rapidly propagate an impulse. We've got what's called 3 pacemaker sites in the heart. Pacemaker means that little cluster of cells is going to initiate an electrical impulse at a set given rate. So if we could take the heart out of the human body, and we could keep oxygen and nutrients going to all the tissues, the heart really doesn't need the body to function. It's its own self-contained electrical pump. Now, our brain innervates it with some nervous control. We have hormones that can kind of work on the heart to speed it up, to slow it down, like epinephrine, adrenaline. But for the most part, the heart, even without that stimulus, will just fire at a given rate, pending everything is maintaining proper oxygenation nutrients. So the SA node, called the sinoatrial node, is located kind of at the top of the right atrium where the superior vena cava connects. That is the primary pacemaker for the heart, so that's what sets the rate. So the SA node should generate impulses roughly between 60 and 90 beats a minute, without any outside influence. So about once a second, or a little faster than once a second, that it's initiating cardiac impulse. So that electricity then moves through nerve bundles through those top chambers and will come together in the center at a place called the AV node, which stands for atrial ventricular. So it's right in between the atria and the ventricles. That impulse is paused there briefly before it's sent down through the ventricles. I think I got to back up just a little bit to explain how that electricity initiates contraction. The cardiac cells have channels on them. So if you think of a cell, like when you're in high school biology, there's literally doors that can open and close on the wall of a cell. And that electricity is what initiates some of those doors to open, some of them to close. And it causes a change of primarily sodium, potassium, and calcium, probably your three biggest players. And not important for you to write this down, but sodium is most prevalent outside of the cell. Potassium is most prevalent inside the cell. So when that door opens, potassium just freely rushes out of the cell on its own, and potassium just freely, sodium freely rushes in. This rapid change of electrolytes changes the charge of that cardiac cell. And as that happens, that creates doors to open where then calcium comes pouring in. And if you look at those cardiac cells under a microscope, it can look kind of like a ladder. Actin and myosin filaments, that influx of calcium causes those muscle fibers to do this. And that's where we get that contraction. In fact, if anyone ever hears of heart medicine, sodium channel blockers, calcium channel blockers, potassium, that's where those medicines work, is at some point in that opening and closing doors and letting electrolytes in and out. So we have to have adequate amount of electrolytes for that to happen, for that contraction. And then at the end of that, we have to move the electrolytes back to where they originally started. And then that requires energy. So remember when I said that sodium just freely rushes into the cell because there's more of it outside? Well, at the end of that, now there's too much sodium in the cell, we have to reset it. So it's got to pump it back out. And it's got to pump the potassium back in. Now that requires energy. And does anyone remember what that energy is called? What's it?
ATP.
ATP, excellent, adenosine triphosphate. So when we're not using oxygen and glucose in the whole cellular respiration, we can't make energy. Sodium potassium pump can't work. And then that whole system begins to fail. It's kind of making sense how it's all ties together. As that electricity, I describe it, if I could line up dominoes, if I had a center aisle here, and that was my electrical pathway in the heart, and I just had rows of dominoes going out to each wall, that if I was the electrical impulse and I just walked by and tapped that first domino, and you can imagine them all going out behind me, that is essentially what that electrical impulse is doing, is initiating that cardiac contraction as well. So it's a very synchronous, it has to be precisely synchronized for our blood to pump effectively. Because if you can imagine, if it wasn't synchronized and our top atria pumped at the same time our two ventricles pumped, what's going to happen? Come on in. Welcome. It's blood doesn't, it's kind of working against each other. So it's got to be that super organizing to get that heart moving. When we throw in heart arrhythmias, irregular heartbeats, and I'll give one, for example, atrial fibrillation. Who's heard of that? Okay, so we've heard of ventricular fibrillation, right? That's what we shock. So atrial fibrillation, it's similar, but instead of the whole heart quivering, it's just the top two chambers. And you've got all these electrical impulses firing simultaneously, and only every now and then some are getting through to the ventricles. So it causes this heart to get kind of irregular. So we lose some of that, I think the term is insidium, don't write that down. But so we lose that atrial kick, that extra little blood we get from the atria squeezing correctly, which means cardiac output just automatically drops a little bit, just being in that rhythm. So all these impulses come together at kind of that point at that AV node in the center. Now, it doesn't show it here, but there is a layer of like connective tissue separating the top from the bottom chambers of the heart. And the reason that separates that, because if you can imagine that electricity went all through the atria and hit the ventricles at all different points, remember the whole domino thing? We're going to start contracting the ventricle at different times. So we really need that impulse to come down to one point and then go from the ventricles and squeeze them from the bottom up. That's why that layer is there. So that impulse only can get through that one center point. Now, if the SA node failed, let's say lost blood supply or some disease happened where that SA node quit, our AV node will sense that, hey, it's been a couple milliseconds since I've gotten an impulse, so then that's going to start to fire on its own. But as we start to go down in the electrical system, it becomes less effective and slower. So the intrinsic firing rate of the SA node, sinoatrial nodes, remember I said, well, technically that's about 60 to 100 beats a minute. AV node is about 40 to 60 beats a minute. And then if that fails, the ventricles, the little fibers in the ventricles will pick up. And that's about 20 to 40 beats a minute. Which now we're getting to the point where it's really not compatible with life. It'll still work, it'll buy you a little bit of time, but we've got a backup for a backup for a backup. Ashley, you can sit up here if you want to. So, as it comes through that, and I'm sorry, I'm jumping ahead of myself. So the big reason it's paused there is imagine this heart's relaxed. You know, it's diastole. It's in between contractions, so blood is pouring in from the vena cava. It's filling up that right ventricle, and then it's filling up the right atrium. At the same time, blood is coming in from the lungs through the pulmonary veins, filling up that left ventricle and then filling up that left atrium. So when the impulse initiates again, the atria squeeze into ventricles that are already full of blood. And what happens if we take a chamber that's full and we squeeze more into it? What's it do? It's going to stretch out a little bit. So each time before that heart beats, our ventricles actually stretch just a little bit because the atria are squeezing more blood into it. That's what we call atrial kick. Then the ventricles contract and inject the blood either to the lungs or to the body, depending on what side. So that impulse is paused there briefly to allow the atria time to squeeze their blood into the ventricles. If we don't have that pause, the atria and the ventricles are squeezing at the same time, and it just doesn't work as well. And by a brief time, it's, what is it, 0.12 to 0.2 milliseconds is our PR interval, correct? All right, thank you. And so we're talking fractions of a second, but that delay is essential, even that couple fractions of a second, to allow those ventricles to get that good squeeze of blood. The impulse then comes down from that AV node, and it has two pathways, the right and the left bundle branch. So you may hear of someone that says, I have a bundle branch block. It's a relatively common, we'll say ECG finding. It just means that one of those electrical highways just isn't working as good. Maybe there might be some disease in that heart muscle, but the electricity hits a chunk of tissue that's dead, and it's still going to get through, it's still going to hit all those dominoes, if you will, but it's got to hit that, and then it's got to take a detour. So it just takes a little bit more time to contract that ventricle. That okay? Make sense so far? All right, I don't need to go much deeper than that at this point. So the anatomical structure, I won't spend much time on this, but remember when I said to you from the beginning, we trace a drop of blood as it moves through the heart. So we'll kind of start the vena cava, right atrium. Who wants to take a stab? What's the first valve that it goes through? Tricuspid. Anyone remember the acronym for valves? T, P, M, A. TP MOM. So tricuspid is the first valve. Tricuspid separates the right atrium from the right ventricle. Then goes through the pulmonic valve into the pulmonary artery to the lungs. Lungs through the pulmonary veins into the left atrium, through the mitral valve, and then up through the aortic valve to the body. So that's kind of your drop of blood second as it's moving through. Now, when people say they have prolapse valves or a murmur or things like that in their history, generally, like when you can imagine, when the heart contracts, two valves are open and two valves are closed, right? Because if it wasn't that way, we lose our closed circuit. So when we're squeezing blood from the atria into the ventricles, we have to open up the tricuspid and mitral valve to allow blood to go. But the pulmonic valve and the aortic valve got to be closed, or we lose that pressure because it's going out through the arteries. And conversely, when we want to pump blood out to the body or lungs, if the tricuspid and mitral valves were open, when the ventricle squeezed, they just pump blood back up through the atria, and it wouldn't generate the pressure to get up through the aortic or the pulmonary. Make sense? If it doesn't, please. This is all going to tie in here shortly. Again, we talked about this kind of a closed system, that the arteries turn into arterioles, which are just small arteries. And then where the artery meets the vein essentially is the capillary. And the capillary is where all that gas and nutrient exchange takes place. It's always at the capillary level. So the heart itself, its blood is supplied by the coronary arteries, which you can see them on, it's the blood vessels on the outside of the heart. And this is where the majority of our cardiovascular problems have to do with those arteries not supplying blood to the right spots of the heart effectively. So the arteries, just like no different than indoor plumbing, that over time, the showers get a little bit slower to drain. And I don't know, I'm trying to look at all you long-haired people. Have you ever had to unclog your shower drain?
Weekly.
Yeah, okay, yeah, I'm looking at all these girls. Me, not a problem. But those, through our natural process of life, is that those arteries begin to harden, they become less elastic. We begin to get plaque and cholesterol deposits around those arteries, and some more severely than others. So these potential blockages of that artery, there's some, I would say there's a lot of genetic risk associated with it, meaning, like if I have someone with chest pain, one of the questions I ask them during my assessment, has anyone in your family had heart disease? Because if they say, yeah, mom and dad did, or dad did, or grandpa did, there's a high likelihood that they did. So despite them doing everything perfect, running, eating right, they're probably going to get heart disease because that's in their genetic code. But there's things that we can do to modify it to make it worse, like sitting around smoking cigarettes, vaping, eating like crap. And I'm not lecturing, okay? I am not lecturing because I am just as guilty of, especially in the winter, sitting around too much, eating like crap, drinking too much. All that stuff can lead to increased plaque deposits, and we're going to dive into that just a little bit too. So with these arteries, and I was hoping we'll come back to it, but there's mostly two different coronary artery systems. So we see two little outlets here that come out of your aorta. So just below them is where that aortic valve is. So when the heart contracts, when the ventricles contract to pump blood out, blood essentially goes right past those coronary arteries and gets sent out to your body. But during diastole, when your heart relaxes and that aortic valve closes shut and blood comes sloshing down and then sits against that aortic valve, it's that passive back pressure that then fills these coronary arteries. And you have the right coronary artery, and then you have the left. And this one here, that anterior descending, you guys don't have to differentiate these branches, but have you ever heard of the widowmaker? So each of these arteries feed portions of the heart, and that LAD, that anterior descending, that's what feeds the primary part of your left ventricle, the part that is responsible for pumping blood and kind of throughout your entire body. So when you have a blockage here on that LAD, they call that a widowmaker because mortality is usually pretty high or higher when it's associated with that. They're more prone to going into shock because they lose left ventricular function. So they can't generate that cardiac output through the heart attack. So, and I want to urge caution because any blockage has a potential to be a widowmaker. Okay. The good news is that therapy today, even when I started in this career a while ago, you know, when I started as an EMT, a heart attack was, I don't want to say 50-50, but it wasn't as good as it is today. So the therapies and interventions that they can do today compared to even 15, 20 years ago are phenomenal. So heart attacks aren't necessarily a death sentence. It's when we don't recognize it and initiate treatment, transport them into the right place at the right time. You can get people to a cath lab and they can come out of a heart cath in better shape than they were when they went in. So it's pretty amazing how fast that treatment can happen. The blood, you know, the components, we kind of talked about this quite a bit. The primary components of blood, red blood cells, which, anyone remember what's the red blood cell's primary job? It's oxygen to the tissues. What's the white blood cell's primary?
Up against infection.
Infection, immune response. What's platelets primary?
Clot.
Form clots. And then our plasma is what carries. It's the fluid that carries it. So any alteration in those levels can create some problems. This is the picture that irritates me quite a bit. So what this is showing is over time, this is a cross section of that coronary artery. It's enough to kind of paint a picture, but it's, I'm going to kind of step outside the curriculum and explain to you really what happens here. So we all think of this coronary artery as a rigid PVC pipe that over time begins to occlude inward. And that's actually not what happens. What happens is what's called coronary remodeling. It's probably hard to see. Bring this over here for those at home. On that diagram that's on the TV, do you guys can, on the upper right one, the one that's wide open, the brand new artery at birth, let's say, everyone can see that? So there's kind of different colors. There's a red, then a pink, and then kind of an odd pink, like 3 layers. So arteries have multiple layers to it. And that middle layer is muscle. And that muscle is what can constrict or dilate those arteries as needed. Remember, if we're losing blood, the vessels will get smaller to try to maintain pressure. Okay? So I'm just going to kind of highlight this picture. So it kind of, if we see that like more of a, this is very, very exaggerated, kind of that egg shape, right? So what I'm trying to demonstrate here is that remodeling, that when you get plaque buildup, the red is showing a very exaggerated amount of cholesterol and plaque. That opening that the blood goes through, we call that a lumen. That's the pipe where blood flow can go. So when you look at the upper right picture, we would say that's maybe less than 5% plaque buildup. So that yellowish stuff here. This plaque. Okay. So I would say 98% of that lumen is open. When we move here, this is probably close to 50% occlusion. So if you've ever heard someone go to the doctor and say, you know, my blood vessels are at 60%. So what they did is some type of imaging, and it's a rough estimation, a doc looks at it, says, I don't know, it's 50–60%. That they don't really take actual fine measurements. This is probably getting close to 80–90% occlusion, and then that is 100% occluded. Whereas this example, if we looked at this vessel in its entirety, you could almost argue this is 50%, 50 to 60% occlusion with this plaque buildup. It's just the plaque is basically pushing the artery outward. But our lumen remains intact. Over the top of this plaque layer, it's kind of defined as a lipid cap. So it's a cap that sits over that cholesterol. Inside of that plaque, there's a bunch of inflammatory factors in there. Same inflammatory factors that if you're hauling an oak brush and gets scratched and your skin welts up, okay, that when your body senses it's an injury, it tries to fix it by making a clot and it swells a little bit to get white blood cells in there. That's what these inflammatory factors do. So if I have a really thick cap that's not going to rupture easy, pretty low risk of a heart attack. But if I have a very thin section of cap and that tears internally, you can't feel it. If that tears, all those inflammatory factors start to get into the bloodstream, and your body has receptors for that says, I'm cut, I'm injured somewhere. And what does your body do to injury? Clots it. So your body senses that, and then what comes along is step one, is all these platelets start to clump up to cover that. So you can see where we had a wide lumen. Now within an hour, it's at like 50% because of all these platelets are clumping up. And then once the platelets clump up, then we start to get these other fibrins that begin to create a mesh over the top of it. So you can see how quickly our lumen is getting small in diameter. And I want to show this take an extra 5 minutes to kind of explain this, because you can have, does anyone know what an angiogram is? So an angiogram, imagine like a real-time x-ray. You put someone on this machine and you can see an x-ray image, you can actually see the heart like beat, right? And when they're going to do an angio or a heart cath, is now through the wrist, but they're going through the wrist or the artery in your leg, and they feed that catheter up into the heart. They go, down where the aorta meets, and they take it and they point it at one of those coronary arteries and they squirt some dye. So you can see this dye as the heart's beating, this darkish color goes in and you can see it flow down the artery. So they can say, oh, that artery looks open, the dye is getting all through the blood vessels, and then they turn it a little bit and they squirt it down the right coronary artery, and you can see it goes down and all of a sudden it stops. Okay, well there's the blockage there, and then they slide that little coil in there and expand it, and that's the stent, right, to open that blood vessel back up. You can have a routine angiogram at 8 o'clock in the morning. Get in your car, and all of a sudden that cap ruptures. And by the time you get home, you're having a massive heart attack. So I want to urge caution, because someone might say, well, I was just at my cardiologist yesterday. I had an EKG last weekend, and everything was fine. This stuff you can be fine, and literally an hour later be having a full-blown heart attack. So that's why I want to keep, so that because once you become a licensed EMR or EMT, Renee, how often do you get called by family members thinking you're their doctor? Okay, me too. When I first became an EMT paramedic, how many pictures of rashes I got?
I have it on my phone right now.
I know. To which I would reply, I have no idea, so I see a doctor. It's starting to smell.
I've got symptoms.
If it's starting to see it.
But so, and I just, it's more so for that education part of Because you're gonna get in that situation someday where someone's gonna call you, hey, Jim, you know, doesn't look good, he's got this chest pain, but you know, he was at the doctor a week ago and they said he was fine. That never get that false sense of security that, well, heart attacks don't happen in a week. No, they can literally happen in an hour. And one of my good friends, we had our full physical at the fire department. At 9:30 in the morning, he left to go home because he came in on his day off. EKG, everything was perfect. At 11:30, he's calling me saying, I think you need to bring an ambulance over, something ain't right. He was in a full blown MI. 2 hours, or less than an hour after he got done with the surgery. So it can happen that fast. Now, can this happen where it goes inwards? Yeah, but this is typically what happens. And unfortunately, when we do an angiogram, we have no idea what that extra plaque looks like. We just know that lumen is open. That's all. We don't know what's on each side, but we just know that the lumen is open. What?
649.
649? Okay. I'll finish up just a little more concepts and then we'll give you a break. Just the EKG, what that is, this isn't, the EMR is certainly, it's within your scope to apply an EKG. You're not expected to interpret it. And we kind of touched on that during vital signs, and we'll probably do more of it Saturday on how to do what we call limb lead placement. So it's a right arm, right leg, left leg. There's some flexibility where exactly we put it, but it's ideally set up that you have an electrode on each wrist and an electrode on each ankle. So they're supposed to be out on the extremities. And that manifests then on the ECG to give us an electrical representation of what's going on in the heart. So on a normal complex, on lead 2, which again, don't write that down, but I'm sure everyone has seen this symbol at some point in your life. What it represents basically is that first little bump called a P wave. That's indicating that electricity going through those atria. Then there's a little bit of pause there, and what that's representing is that pause of the electricity being held up in that AV node. And then that big spike represents the ventricles contracting. And then there's another little bump after that, and that's representing the heart resetting, getting ready to fire again. So when we do the EKG, that's what that is all represented. Blood pressure, we talked about that. Okay, I think now would be a good time. We'll take a quick break, and I just wanted to get through that basic A&P recap, and then we'll start moving into the actual types of emergency. All right, well, I'm going to get this party moving again.
Yeah, Jay.
So when we look at cardiac complaints, 911 calls, we're going to get, we can really kind of narrow down the types of calls we're going to get. And again, at the EMR level, it's not super important to differentiate. It's more important to identify triggers for life-threatening conditions. So first off, we'll just talk about rate-related problems, which the text or this doesn't go over. There are several conditions that cause a heartbeat either too slow, where its rate is slow enough that it's not generating enough cardiac output. It's too slow. Some of it can be just normal disease process in the heart, something where like the SA node quits working or the AV node quits working. And it doesn't have to be a blockage of a vessel, it doesn't have to be a heart attack, just normal disease. So when we get those electrical type problems, creates arrhythmias, which are abnormal heart rhythms. And the one category is bradycardia, slow heart rhythms. And there's a bunch of different rhythms, but regardless, the big problem with those slow heart rates is first we have to rule out the most common cause of slow heart rates, which is hypoxia. So if they're breathing and talking to you fine, then it's not hypoxia. It's probably a rate problem with disease into their heart. Now, kind of the rule of thumb is we generally don't see sick patients until their heart rates start to get less than 40. So even in the mid-40s, at least my experience, people are relatively stable in that point. And some people might have normal heart rates in the 40s. People who have normally slow heart rates, these are athletic people, for the most part. People who do a lot of cardio run slow heart rates, but if we go to a home for a 72-year-old guy that's 360 pounds that smokes 2 packs a day, and his heart rate's 30, I can tell you he's not an endurance athlete, and this is probably due to a disease problem. Okay. But once we start to see those heart rates, kind of for me, 40 is that trigger. That's generally going to need some type of intervention to fix that heart rate, for the most part. Now, some people can actually tolerate that, and who's heard of Lyme disease? Anyone ever hear of Lyme carditis? So Lyme carditis, some people get Lyme disease, that if that migrates into the heart, can actually cause what's called a 3rd-degree heart attack. So it's a super slow heart rate. I've actually seen it several times in my career, and I always say it's usually a male. If you've got a guy who's otherwise healthy and you've seen a 3rd-degree heart block, it's Lyme disease, don't prove it. We see it frequently enough, but of those people, and I can think of the last one, the guy was in his 30s, heart rate was like 28. He had good blood pressure, he was talking, he called us because I feel like I'm gonna pass out when I start working in the shop. So yeah, my heart's only beating 1/3 of what it should be. So, and it turned out he had Lyme disease. I had a family member that developed Lyme carditis from it. So the good news is, about 48 hours of doxycycline and your heart rate goes back to normal. That's the good news.
Does that get rid of it completely or just?
Well, I mean, I don't think you ever get rid of, when you get Lyme disease, I don't think you ever get rid of it. You're gonna have to deal with some stuff with the rest of it. Just welcome to life. What's it?
You don't get rid of it.
You don't want it?
You don't get rid of it.
Yeah, it's always gonna be. So you just gotta.
Symptoms just kind of.
Yeah. Yeah, and actually, I should bring the experts, because isn't the Woodrow Clinic like top of the nation for Lyme disease? So I was getting at slow heart rates. So generally that kind of less than 40, so if you're checking a pulse and working on a pulse in 30, it's a huge red flag. There's not much we can do as the EMR. Have an AED ready, but they're going to need advanced life to help kind of correct it. On the other side of the spectrum is fast heart rates. Fast heart rates generally can also be caused by a disease process. So kind of the trigger for fast heart rates for me is roughly that 130 to 140. When you start to get above that, it starts to get a little bit concerning. So I think the fastest heart rate I've seen in an adult is about 240 beats a minute. Yeah, and that's going fast, like you feel their pulse and you can't even really get a pulse rate, just cranking. It's kind of like a short circuit in the heart's electrical system, where it's just kind of this impulse is just spinning and just shooting rapid impulses. The fast heart rates also require kind of ALS intervention. But if you're checking a pulse and the heart rate's 140 or greater, it's likely a rate problem and it needs medicine or electricity to fix it. Again, not much we can do intervention-wise, just try to get on the radio, let your ambulance know as soon as possible that you got a super fast heart rate. Yeah, I think that's kind of enough of rate problems. The other cardiovascular stuff has to do with generally either your pump is not working effectively, which we'll talk about heart failure, or you've got a blockage, blood flow to your heart muscle is being disrupted. usually through a heart attack or blockage in one vessel. So that brings us to kind of what we call acute coronary syndrome. What ACS is the common acronym, and it's acute coronary syndrome is an umbrella description of everything I just mentioned, be it heart rate problems, heart rhythm problems, coronary artery problems, heart failure problems. They're all within that acute coronary syndrome window. Some terms that we're going to talk about. So angina or angina means pain. And one slide that's going to come up is going to say angina pectoris, which I have not heard that term in years. But angina pectoris means chest pain. So pectoral pain. Ischemia and infarction. So we kind of call it the three I's, and it's leading up injury. So ischemia means tissue is lacking adequate blood supply. So it still has some blood supply, but not enough. The demand is exceeding the supply. So if I put a tourniquet on, so I mean, even just not a tourniquet for bleeding, but I put an IV tourniquet on for a blood draw, I'm creating ischemic tissue. And you know, if you ever got a blood draw where you're taking a blood pressure and you're taking too long to bring the cuff down, you start to see the arm kind of turn red, discolored. You're making the arm ischemic for a little bit. But we can recover once we restore the blood flow, right? Ischemia that continues to worsen without intervention now begins to lead to injury. And injury is where some of the cells start to have almost irreversible damage. And then we go to the next I, which is called infarction. And infarction means tissue death. So myocardial infarction is tissue death of the heart muscle, also known as a heart attack. This is where you'll hear us use words, and sometimes I seem to thinking MI. MI stands for myocardial infarction. So ischemia leads to injury, injury then leads to infarction, and this can happen over a period of hours. From the time a coronary artery starts to plug up, immediately your muscle gets ischemic, and then within minutes to an hour moves into injury to the muscle, and then can move into actual muscle death or infarction. So angina, I'm just going to say angina, but angina basically just describes someone who calls that they're having chest pain. At the EMR level, we really can't differentiate. Is this angina? Is it a heart attack? Is it a pulled muscle of the chest? I mean, it could be any of the above. But for the most part, if someone says they're having pain or discomfort around their chest, that we're going to, for the most part, at the EMR level, just assume this is a cardiac-related chest pain and treat it as such, okay? For us to really differentiate, and I even got to back up, that when we look at a myocardial infarction or a heart attack, there's additional categories of those. So has anyone ever heard the term STEMI? So STEMI stands for ST elevation myocardial infarction. And if you've ever heard of an NSTEMI or non-STEMI, that's a non-ST second elevation myocardial infarction. But the EKG, the 12 lead, gives us a pretty decent differentiation of them. But in case you or anyone you know goes to the hospital with chest pain, they're going to do a couple things. They're going to do EKG, and they're going to repeat it. So I can show you multiple examples where I can do an EKG when I get into something. And then 10 minutes later, take the EKG again, and it looks different. It can actually change. In fact, Dave, you probably remember one guy, when we were rolling in the hospital, I went, oh, thank God it's a heart attack. Because he was having acute coronary syndrome symptoms, but his EKG was normal, and I was worried it was a dissection of his aorta. But then when his EKG changed as we were getting to the hospital, you could see it was a heart attack. It's like, we could fix that a lot easier. We could fix that. I mean, if I had a choice, you want an aneurysm or a heart attack, I'll take a heart attack every day. The outcome's much better. So EKGs can change. The other thing that the hospital will do is they'll check your blood. And I'm kind of giving you this because as we ask, we're interviewing patients, and heart patients tend to have had previous heart problems a lot of times, so they're going to be using these terms. I want to give you just a little bit of a background. But the main blood test they're going to look for, it's called troponin. Not important for you necessarily to write it down, but when heart muscle is injured, specifically heart muscle, that it starts to release things into the blood. And one thing heart muscle releases, it's called troponins, and they can check for it in the lab. If I start having a heart attack now, it's going to be about 4 hours later before that troponin shows up in my blood. So troponin isn't a real good indicator for immediate heart attacks, but it tells us there's been some heart damage. So if I go to the hospital with chest pain, they do an EKG, and the EKG's normal, doesn't change, and they check my blood, my troponin's normal, and then they check it again 4 hours later, and now it's going up. Now I have what's called a non-stent. The difference between those two types of heart attacks is what we call the STEMIs. They have to go to a heart cath lab right now. That's an emergent, get them on a helicopter, get them to an interventional cardiologist. The non-STEMIs, the ones where the EKGs aren't changing, but it's that blood levels going up, they're managed what we call medically. They get admitted to the hospital, they get put on blood thinners, they watch them for a few days, and then they schedule a heart cath within a week or two. So, two different things, but when people say they've had a heart attack, that's one thing we can ask. You know, did you have to get a stent put in, or open heart bypass surgery? Does everybody know what a bypass is? Who doesn't? That's good. So bypass surgery, they can still do, but usually when you hear someone who's had a bypass surgery, that's a pretty good indicator of significant heart disease. So when they do a stent, and I kind of alluded to before, where they imagine we're going back, we start the dye in, and we see the blockage. So they run they run a wire kind of through that blockage, and there's little lines on this catheter so they can get it so it's in the clot. And then they have a balloon, and on top of that balloon is this metal coil, basically. And so they get it in the right spot, and they blow this balloon. And it takes that metal coil, and it expands it, and then they drop the balloon down, take it out, and that stent, that metal coil stays there, and that's a stent. So people who have had that treatment might say, I've had 3 stents put in. That means there's 3 different clots that they put stents in. But if they're going in to do that, and they can't get that through the plaque because it's so thick or so hard, or just the disease is too much, they don't have enough stents for everything, they might do what's called a coronary bypass. And the term we call a lot is CABG, because it's CABG is how it's abbreviated. So a patient might say, I've had a CABG. And you know, when you expose their chest, you'll literally see a scar. So what they do is they take that blood vessel that's blocked, so if this is the blood vessel, and the blockage is here, they will take a blood vessel out of somewhere, probably your leg, and they bypass that blockage. They create, so if you've heard of, I've had triple bypass, that means 1, 2, they've had to do 3 different bypasses around the clot that they couldn't open up. So that's what that means.
Hey, how often do stents fail?
Oh, stents?
Yeah.
Oh, gosh, I don't know. I'd say, I think, last I knew, probably, I've known in as early as maybe 10 years, you can get stent failure, but I would assume stents can probably fail. Really, I mean, I know people who just get a new hip and they're going home from surgery and it breaks again. So I can't, you know, I don't know, have you heard, like, on average? I mean, they don't last.
Yeah, my dad had like 4 stents in and backed away from his 4th
And it could have been a different, you know, so those stints are about, stints are about that big.
You're tiny.
So we open up this blockage, but then next year we get another blockage just past there, just before. So, you don't stint the whole vessel. It's, I don't know, I think what I've seen stints are not that big. They're not really big. But does anyone, when they blow up that balloon, anyone want to take a stab on how much PSI is in that balloon? 200.
Holy shit.
Yeah. And I didn't realize that till like you pump it up to what? I would have thought the vessel was just, like, yeah, 200 PSI.
That's crazy.
Just for a second, and then it breaks down. It's pretty, which is why, this is why not every hospital can do heart caps. So when we bring an emergent heart cap in, and we go to the catheter suite, which is like an OR room, across the hall, they've got a surgical team ready. So every heart cap procedure, you've got your cap team, and then across the hall, they have a surgical team just ready in case something goes wrong, that they unlock the stretcher, bring it to the other room, and go to cardiothoracic surgery. So it's a pretty, when you're doing emergent catheterizations. Now, they've got a semi-trailer that backs into hospitals, and they'll do angiograms in a semi-trailer. But emergent type stuff, you need interventional cardiology. And the closest here, I think, is Wausau.
Yeah.
Right? Yeah. So Wausau's our closest, Wausau, Weston, Marshfield. I don't know about that way, Duluth maybe? Superior? Yeah, I don't know. But anyways, there's really kind of specialty hubs that we have to get those patients out to. But angina, so angina, if I've, angina is usually a percussor to something happens. So, take me for example. So I'm gonna be 50 this year, not spring chicken anymore, but so next winter, I'm out shoveling my driveway, shoveling the deck, and all of a sudden, I start to get some pain. So what's happening is that rigorous activity, my heart's beating harder, that my demand for oxygen and nutrients in my heart cannot be met by the supply, because my vessels might be narrowed, that I can't get enough blood supply to feed that. So the harder my heart works, the more oxygen and nutrients it needs. So demand supersedes supply. So I get the symptoms of what happens when my heart muscle isn't getting that, is that's what gives me my chest discomfort. And I might get nauseous, and I might get sweaty, and my skin starts to change color, and some kind of extreme. So then I sit down, I rest, sit down in a chair, grab a glass of water, just kind of calm down. My heart starts to slow down, my supply and demand begin to meet normally, and the symptoms go away. So that's kind of angina. And then you might have heard different terms of stable angina and unstable angina. So stable angina, for the most part, is predictive. So that's someone who a doctor might prescribe them nitroglycerin. Say, we did a cath, it's not bad enough that we have to do stents or anything yet, but if you start to get chest pain, sit down, rest, and not like take a nap, but just stop the activity, sit down, pop a nitroglycerin, and what nitro does is it kind of makes those arteries a little bit bigger to allow more blood to get through. So stop the activity, rest, take a nitroglycerin, and you can do one nitroglycerin every 5 minutes, up to 3. So sit down, rest, take 3 nitros, not all at the same time. Take one, wait 5 minutes, take one, wait 5 minutes. And that's what a lot of people do, is they take 3, and then their blood pressure drops, and then so if after 15 minutes of rest and nitroglycerin and you're still having pain, call 911. Okay, so that's kind of people sent home, and there's a large portion of people out there that have this chest. So now it's been 20 minutes and this person's still having pain, this is where we get called. So we're coming in, is this just a really bad case of angina? Is it a heart attack? We don't know. It was EMR, but we're going to start the treatment. And that's kind of stable, that they can predict it. Unstable angina, if they, and it's not like they necessarily gotta go through all these stages. You can just go from normal to a heart attack, you can skip that whole angina thing. But, it's now called unstable angina when chest pain just happens where we don't predict it. So I'm watching TV and all of a sudden I get chest pain. That's now, they call it unstable. Now this is where your doc says, okay, we're gonna go to the next level, probably schedule an angio and start looking at things a little bit more. When the pain doesn't go away and that blockage is permanent, now you move into what's called a myocardial infarction, or we actually call heart attack. And again, just kind of, so this is just kind of showing a description that we've got some blockage in this artery right here, and we can kind of see where it's looking a little bruised color. So that whole section, and what we're looking at here is that's actually the left ventricle, is that heart muscle there cannot pump effectively because it's not getting the oxygen it needs, it's starting to fail, so it's not able to contract as well. We're starting to lose some heart function. And this is just gonna continue to deteriorate over the next hour or two until we restore blood supply. And now you gotta remember that electrical system runs through there too. So if the cells get to the point of tissue injury, that they don't allow the propagation of electrical impulse, that heart can all of a sudden go into a V-fib. So someone who's having a heart attack, or high risk or high acuity, meaning they can go, they might make it 4 hours, they might live through it, or they can just go in cardiac arrest immediately. So if someone is having chest pain, we definitely want an AED handy. We don't necessarily need to hook them up, but have it right here. You know, the women, diabetics, and elderly, just a little bit about silent MIs. Has anyone ever heard of a silent heart attack? So silent heart attack is a heart attack without chest pain, basically. 3 categories of people, higher risk for it. Elderly, and we know elderly because of neuropathy. They don't sense pain as well anymore. Diabetics, because they also have neuropathy. You can have a diabetic literally break his leg, and they're in no pain. Like, I don't feel it. And women, see, mostly because guys are just difficult.
Yes.
But I don't know. Women, and so an elderly female diabetic, she's a high risk for like not having chest pain. Like, she'll just call an ambulance because they'll tell you something doesn't feel right. Maybe pale skin, maybe nauseous, extreme fatigue. You know, when they say a heart attack, short of breath, and I want to portray that as they're not like struggling to breathe. They'll just tell you, I feel like I can't catch my breath. So they're saturating well, respiratory rate's normal, no abnormal lung sounds. They just feel, what's classic is the pain feels more like a pressure, like something, you parked a truck on my chest. It's just this painful pressure. And that can be, I would say, anywhere between here and here. We've even seen heart attacks where they're like, oh, it just feels like I got a big bruise between my shoulder blades on the back. For our staff on the ambulance, anyone who has any discomfort within 25 feet of the heart, they get an EKG. Here. What is it? Yeah, and you know, lightheaded, but I think most concerning, the one thing I've seen pretty unique among heart attacks is skin color, is that they get in, and it's hard to describe, I don't want to say pale, but have you ever looked at someone and go, oh, you do not look at this? Yeah, so it's like automatic, like you walk in the door, and you see them, and then the other thing I see a lot is diaphoresis. So they're sweating when they should. You know, so the guy that just got done going for an 8-mile run in the summer, we would expect him to be sweating. Someone sitting in an air-conditioned house and they're literally just shirt is soaking wet, that's diaphoresis.
Are there any, like I understand, like so heart attacks can happen to anybody at any time. Are there warning signs?
Usually before before a heart attack, and a good question, is that a lot of times people have these angina episodes. Unfortunately, especially men, is that men tend to be prideful, and we'll get chest pain when we're out in the yard working, and who are we gonna tell? Nobody. So we're gonna sit down, we're gonna rest, pain goes away, we're like, okay. And then we get this crescendo, where like, when we're doing an assessment, we'll ask them, have you had pain like this before? And then they'll say, well, for like the last month, I noticed it's becoming more frequent. But not all the time. Women, for the most part, before menopause, it's pretty rare. I wouldn't say impossible, but rare for a premenopausal female to have a heart attack. And actually, studies were done on this, and it has to do with estrogen. Estrogen is a very protective hormone. So when you look at rates of heart attacks, let's say under the age 45, that males way outpace females. But then about age 60, they quickly equal. Now what's the difference? Females are making estrogen. Estrogen is a highly protective hormone. So it's not impossible, especially if you have some genetic, like things that are called like LDH receptor deficiencies and things like that. It's not impossible, but kind of rare. And I would say for my most part, my MIs in females have generally been at 55 or older. Whereas males, we can see heart attacks, I think the youngest non-drug related I've seen, early 30s. That I know. So, but otherwise you mix in drugs, someone like cocaine, right? I just think of that, cocaine is a health drug. Cocaine, any of those sympathomimetics, they can actually take those coronary arteries, so you can have a heart attack from cocaine. And it's not because of the blockage, but the cocaine actually takes your coronary arteries and spasms and shut. So they get no blood supply. And the scary thing with cocaine is you kind of don't know how you're going to respond to it. So, I mean, there's some people that can use cocaine, and like, I shouldn't say I'm not advocating for cocaine use. So don't ever take that as what it is.
Well, that's better than my neuroscience professor said, if we were going to choose one drug, do it, cocaine over heroin.
I'm not gonna, but I did have a death of a 23-year-old man who did cocaine for his first time and went into cardiac arrest from it. So, and I don't know if anybody, and we'll just, might as well go down this because cardiovascular emergencies is my favorite topic. Cannabis use. Cannabis. Let's go down this road briefly. There was a study, and I can find it actually came out of the Marshfield Clinic, where there is a link between advanced or accelerated coronary artery disease and cannabinoids. In a certain portion of the population, more studies are needed to figure out why. So the gist of it being cannabinoids, they studied chronic cannabinoid users. And no differentiation between smoking, edibles, cannabinoids. So whether it's gummies, smoking some ditchweed, it's all the cannabinoids. And they found a large group of these people that, we're talking late 20s, 30s, severe atherosclerotic cardiovascular disease. Now, they believe it's linked to a certain genetic code and how it responds to the cannabinoids. But they haven't identified what that is. So maybe 5-10 years from now, they can do some genetic testing, blood work, and say, hey, you smoke some ditchweed, you're probably gonna have a heart attack because you've got that code for it. So, but it was, this came out maybe 2 years ago. Katie, did you see that? No? All right, yeah, just
So
keep doing it.
What are they higher risk for? What are they at higher risk for?
Heart.
So, because I've seen again, in my neuroscience test, we saw the effects of like someone with Parkinson's who smoked weed or like had a gummy, and you could slowly see their body go out of those.
Yeah, and there's, I'm also a big fan of opening up the study of cannabinoids, because I do believe there's a lot of good things that come out of it, but it was just a very interesting study, you know, that I read, and I start to reflect on a lot of the younger MIs I had that probably had chronic cannabinoid use, and I think chronic cannabinoid use was defined as 3 or more times a week.
That's the first I've ever heard that.
Yeah. I mean, most people call that Monday morning.
6.2 times more likely to experience a heart attack if they're under the age of 50.
Did you find it?
Heart attack risk. Consumers under 50 are 6.2 times more likely to experience a heart attack, and the study was published by the Journal of American College of Cardiology, and they are 4.3 times more likely to have an ischemic stroke in their younger years. And it's because it increases heart rate and blood pressure and creating shear stress on blood vessel walls. And they compare it to regular smoking. And whether you consume it either way, it still causes the same damage. So gummies don't change any different.
What about like oil that seeps through the skin?
It looks like, so you have to remember that any chemical, if it's gonna have an effect, it doesn't matter like the way necessarily that it's consumed all the time, it depends on the receptors that it's going to affect. So even if it's an oil that goes through the skin, right, because if you think about like some of our medications, we can actually apply it through the skin. So it's called transdermal, and it will still have similar effects as if we give it IV, it's just the rate at which you are exposed to that chemical, and it causes the change. So you're still at the same risks regardless of method of consumption, depending on. Now, that could be different if like, say it's not broken down in your bloodstream and it's broken down or absorbed in like your GI tract, and if you bypass the GI tract, so there's some medications that they do say rectally or like the suppositories, that's gonna have a different effect because of where it would be absorbed or how the body is able to process that. So like if you've ever heard of boofing, where the kids use tampons and soak them in alcohol and put them up their anal.
What?
That bypasses the liver and goes straight into the bloodstream.
Woofing.
And
You ever heard of
so-
woofing?
When they do that, it is exceptionally toxic to the system, and very small quantities of alcohol will cause severe impairment because it hasn't had that first liver pass where your liver would.
We get a lot of meth woofing in Rapids.
Oh.
Where they put meth in a tampon and stick it up their butt?
Nope,
Yeah.
take a needle. Well, they were doing it to each other. So, again, not within the scope, we're not gonna practice that, but, yeah. Okay, let me get
My
back
fact
to
for
it.
today. Thank you, Jason.
So, what do we do when we get the chest pain call? And emergency medical care for angina, and we're just gonna call it chest pain. So remember at the EMR level, we don't know this one. And I'm gonna be honest with you, even a paramedic, where I said EKGs can change, we can do an initial EKG on chest pain, it looks perfectly normal. But they're sweaty, they're pale, they're complaining, you know, it quacks like a duck, it walks like a duck, it's probably a duck, we're just not seeing it yet. So we start treating for a heart attack, but then we repeat that EKG, you know, 15, 20 minutes later, no, there, we're starting to see it evolve and change. So what do? Obviously manage airway and breathing. Now, most chest pain patients, they have an airway, they're breathing appropriately. Most heart attacks actually don't need supplemental oxygen. So we tend to think, oh, their heart starves of oxygen, they need oxygen. Well, that's not necessarily the case. In fact, if we give them too much, so let's take someone who's got a oxygen saturation of 98%, and they're having a heart attack, and I put them on a non-rebreather. I can give them a shit ton of oxygen. It's not gonna get past that clot. So what happens is when we hyperoxygenate, the high oxygen levels can actually cause those coronary arteries to start to constrict a little bit. So we don't want to do that. Okay? But check their oxygen levels. If they look like they're struggling to breathe, it might be appropriate to put them on a nasal cannula. Or if their oxygen, if we have a pulse oximeter, if they're in the lower 90s to mid 90s, maybe put them on 1-2 liters of cannula. That would be appropriate. Check their, we're gonna feel their pulse, and sometimes a heart attack can cause that heart rate to get slow. I've rarely seen a super tachycardic or fast heart rate heart attack. They're usually normal to slow heart rates. Blood pressure can be low, normal, or high. So blood pressure depends on where the point is or where the heart attack is will affect where the blood pressure is at. So could be normal. But I would say first, the most important thing that they don't talk enough about is just being there, talking to them, doing that assessment, asking that OPQRST, what were you doing when the pain started? Is there anything that makes it worse? Is there anything that makes it better? But when you're talking to them, it kind of gets their mind off of what's going on a little bit, and helps calm them down. So when we calm somebody down, what's their heart rate? Starts to go down. And when the heart rate goes down, it's not using as much oxygen and nutrients. So just the fact of calming them down, we're buying time without doing any medical intervention, just being there and calming them down. So that's probably the first and foremost. Position of comfort. At the EMR level, one medication that's in our scope is we can give aspirin. So we need to make sure they're not allergic to it. That they don't have any, I always ask, do they have any, like, did you just throw up a toilet full of blood 5 minutes ago? You're not actively bleeding somewhere. But we can give them aspirin. And we use baby aspirin because you can chew it. You could chew an adult aspirin, it's going to taste horrible. But we generally give 4 baby aspirin. Even if they take an aspirin every day. If they're having chest pain, we give them 4 baby aspirin. And chew it up. And what aspirin does is, remember that picture, that first stage where all those platelets start to clump together? Is aspirin makes those platelets more slippery. So they can't clump together as much. So it's not breaking down any clot that's there, it's help preventing the clot from being bigger. There's relatively, even that dose of aspirin, I'll be honest with you, like, I look at the pharmacist, 324 milligrams baby aspirin, if they do have a GI bleed, is it going to impact it that much? Versus the benefit if they're having a heart attack is huge. So there's very low risk by giving somebody 4 baby aspirin, unless they tell you, my tongue swells up and I quit breathing when I have aspirin. That's appropriate to withhold. Okay? And if they're having chest pain, the last thing we want to do is give them aspirin so we can give them ibuprofen. Please don't do it. And really that's about it, is we're going to focus on digging a little deeper into OPQRST, trying to get as good of a picture as we can. The sample history, I always kind of prioritize. I always think, if I can ask 3 questions to this patient before they go unconscious, what are the 3 or 4 questions? Are you allergic, like stop breathing, to any medicine? Because if you go out, I don't want to give you that medicine. And then, I like to know how bad if it's a chest pain, how bad is the pain and how long has it been going? Those are kind of my 3 big questions that I like to ask, and then I kind of fill in with everything else. So a lot of what we're going to do at the EMR with a chest pain or suspected heart attack is just kind of assess. So again, and there's a lot of different, nobody presents the same. Kind of talk about all that. Aortic aneurysms or dissection. So remember how I said that the arteries have layers? So you got that muscle layer and then that outer layer. If there's a tear through some of those layers, like think your big aorta, but it doesn't go all the way through. So what can happen is blood kind of sneaks in between those layers and starts to bulge out. That's an aneurysm. Can happen in any artery, can happen in an artery in the brain called a brain aneurysm. But most common aneurysms that we're worried about are aorta. So the aorta comes up off the heart, that's your ascending, transverse, and then descending aorta. And then when it hits your belly, we call it the abdominal aorta. And then when it gets down here in the pelvis, it splits into right and left, go down your legs. So usually somewhere between here and here, you can get an aneurysm. So abdominal aneurysm would be AAA is here, thoracic aneurysm is in the chest. Some people have these, that they know they have them, that it's very, it would be reasonable for you to be doing an assessment of someone, going through your sample history, and they say, I have an abdominal aneurysm that the doctor is watching. So anytime they try to repair aneurysms, super, super risky. You gotta remember, this is the main culprit. So to fix it, go out to a city, dig up a water line and try to fix it without shutting the water. So you can imagine logistically, it's kind of a tough surgery, right? They can do some procedures to them, I think mesh, or I don't know, they do, it's like a form of an aortic stent, or, so there's different, but all super risky, right? So when an aneurysm is certain size or less, a lot of the doctors say, just come in every month or 6 months, we'll take a picture of it, kind of see, is it growing, is it staying where it's at? But if they have an existing one, it's at risk for dissecting. We're starting to open up more to the point of bursting. Depending on the symptoms of it can be very abrupt. Where if someone has just an aneurysm, that they kind of got a bulge in, and I'm sure you guys have seen it with a tire sometimes. Tires get that little bulge on them, and it means what? You take it off the car and the bike, right? We don't keep. Because what happens if you keep riding? Bad things happen. You go over handlebars. So you know, if we just kept riding that bike with that big bulge on it, it's just a matter of time before it bursts, right? So, but with humans, they're like, let's just watch it a bit, but they're at risk. So this can happen at any time. When it starts to dissect or it starts to tear, and this is before it bursts, and this is a little dramatic, but before it bursts open, it's starting to tear more and more. It's usually described as a sudden, and it's a severe, almost like ripping pain, sharp. If it's in the chest, they may have chest pain, but this is where they may say, it feels like someone's dragging a knife through my chest. You know, that's more suggestive of an aneurysm than a heart attack, and again, we can't really differentiate the two. They can get pale, sweaty, shocky. In the belly, they'll the same type of tearing, ripping sensation in their belly. And actually, what's really kind of depending on where that aneurysm is they'll be like, I have sat on the shitter like 20 times today and nothing's happening. I feel like I have to take a big shit. And that's because that aneurysm is actually pushing on that part of the rectum that tells you, hey, something's got to come out. So that's a huge red flag. They're pale, sweaty, my belly feels like someone's taking a knife to it and I just got to take a shit. No. We should probably go see a surgeon. Now, the thoracic aneurysms, there's not much we can test for pre-hospital. If it's severe enough, you might feel where I can feel a pulse on this side, but I can't feel it on this side. Or the blood pressures are different on each side. It depends on the severity of where the aneurysm is. I've never seen a dissecting aneurysm that the patient looks stable. Like you walk in the door and go, we gotta go right now. These are super, super quick surgical, but we need to get them to a surgeon as fast as we can. I think I've only seen it once or twice, but when you're palpating a belly, like during the assessment, sometimes I'll take my hand and I'll just put a little light pressure, and if I can feel this pulsatile mass hitting my hand, that if the aneurysm's big enough, you could potentially literally feel that pulsing. On a really, really thin person, I think take like we'll just say like end of life, we go to a nursing home, and a 90-year-old guy, emaciated, no aneurysm, I could put my hand and feel it anywhere. You know, that's a pretty big pipe, so it's not a, we don't like to teach it because it's not a super good diagnostic test yet. We just say, it's just above an aneurysm, we gotta go. And there's not much that BLS paramedics can do. We put a couple big IVs in them, just in case, and hoping that maybe if we, but when they burst, it's a big pipe, and you can lose volume super, super fast. There, that's kind of showing how that's a good, showing that little tear. So blood begins to leak into this space and will balloon that vessel up. Talking a lot about that. So heart failure, you know, what time is it? I think let me just hit heart failure quick, and then if we can, take a 5-minute break, and I'll try to get through the next unit, and then we'll cut you guys out for the night. But, so heart failure, like we can go into this pretty deep. We're not going. When we look at heart failure, it's generally, you'll hear definitions of right heart failure, left heart failure. So, for example, this diagram, it uses this term left ventricular hypertrophy. You can see this left ventricle, see a lot more muscle, right? It's just showing that this ventricle has got hypertrophy, which just means enlarged chamber, due to multiple different causes. Could just be genetic disease. You can get heart failure from previous heart attacks. Basically, what heart failure is your heart or a portion of your heart just isn't pumping effectively anymore. So there's, if you think like the example of the hypertrophy where the muscle gets so big and your heart that if it's working really, so someone who's got chronic high blood pressure and that left ventricle every day is pumping against this increased pressure. It's got to push against this high blood pressure to get your blood right. What happens? What would your legs look like if every day you just were on a squat rack doing this? It's going to get bigger, right? The heart muscle is a muscle, so the harder it's working, it's actually going to get more muscular and bigger. It's not necessarily a good thing. So it can get so muscular that it loses its ability to stretch and contract. Think of the body, like me but different. You know, when you see the bodybuilders, like they probably struggle to like what? Because they lose that flexibility, right? I should ask them. You guys do that. You find a bodybuilder, ask them how he weighs. Come back and tell you what he's saying.
I remember the coach.
But these kind of, what I'm saying is the heart gets so big that it can't effectively pump. So depending on what side of the heart, and if you think about it, we had talked the right side of the heart pumps blood to the lung. So if we have one ventricle working better than the other one, we're going to get, blood's going to be back in line. Because one side's pushing out blood faster than the other side can pump it. So when we look at the right heart, where blood is going to back up is where it's coming. So we get increased capillary pressures with right heart failure. That's where the ankles start to get a little swollen. They start to get water leaks out of the capillaries because of that increased pressure. Their neck veins start to stick out a little bit more because blood's backing up. It's not dumping into the heart. Whereas the left side of the heart, that's getting its blood from the lungs. So when the left side isn't getting pumped out, it backs up in the lungs, and that's where you get that fluid buildup. So pulmonary edema is the same thing as fluid buildup in your ankles and your neck. When we get called to a heart failure patient, it's usually a combination of right and left heart failure. So we usually see some neck vein distension with some pulmonary edema. So heart failure patients generally will activate 911 two reasons. So if it's the right heart failure, and their left ventricle's pumping the blood out normally, but the right can't put any into it, their blood pressure drops. When I talk about different types of heart attacks, so we take someone who's having a heart attack to the right ventricle, that's essentially acute right heart failure. And acute means now. So a right ventricular heart attack, when we take their blood pressure, might be like 70 or 60, systolic, or top. And it's because that right heart can't, so when they say if they're having chest pain, give someone nitroglycerin, nitroglycerin drops blood pressure. So what happens when I give, for that person at home that is having chest pain, it's a right ventricular MI, and they just know if I have chest pain, take nitroglycerin. Yeah, I mean, you can see where they can get worse. So this is why I don't think you'll see nitroglycerin added into a scope of practice without the ability to do an EKG. And with EMTs, they put a really super, like, you gotta make sure their blood pressure's at least this before you give them nitroglycerin. But, so right heart failure patients will call 911 because their blood pressure drops. So they're getting dizziness, lightheadedness, so they're passing out. Left heart failure patients call 911 because they can't breathe. They go into this pulmonary edema. So they can have heart failure, be living normally, and all of a sudden something changes just a little bit, and they can go into pulmonary edema within like 5-10 minutes. They can't breathe because their lungs are filling up with fluid. So they'll call us. So what do we do if we're concerned? Most heart failures, they might not necessarily have chest pain. Aspirin really isn't going to do anything for them at this point. So if they feel like they can't breathe, for the EMR level, we treat them as a respiratory patient. And if we listen to the lung sounds and they're in left heart failure, what might we hear? Wet, that pulmonary edema. And what do we do for people who can't breathe and have funny lung sounds? Give them oxygen. Yeah, so oxygen, now, you'll listen and you might not hear wheezing. So wheezing is kind of your indicator for albuterol. Now, is albuterol going to necessarily hurt them? Not too much. But albuterol, I usually think like restrictive reasons. But oxygen, and with heart failure, pulmonary edema, they're going to have really low oxygen levels, 60s, 70s. Like they can progress from respiratory distress to respiratory failure very, very quickly. And I love the textbooks. They'll talk about frothy sputum. You might see them when they're actually coughing up and it's like bubbles. Katie, have you ever seen someone coughing up frothy sputum and talking to you?
No.
No. When we see frothy sputum, it's when they put a breathing tube in and it's bubbling up into it. They're not like just, oh, excuse me, I got some frothy sputum. That's a very, very late stage. It's like a deviated treatment. The other patient, you're gonna get called because they're passing out, and you're gonna check their blood pressure, and it's 60 over nothing. So what do we do for those patients? We position them. So if someone's blood pressure is really, really low, what's something we can do as an EMR to help buy some time? Let's say you come to my house, and I'm slumped over in this chair, and my blood pressure is 50 systolic. What could you do?
Sit down.
Yeah, get me on the floor and get me flat. So just getting someone who can help restore blood pressure, and we've seen it in, I'd see the most common manifestation in Sunday morning syncopes. And I say Sunday morning because it seems we every now and then we go to a church or someone passed out at church. Anyone want to take a stab on what type of denomination we go to free to every one of others?
Catholic.
Catholic. And why is that?
Because they stand up and stuff.
Position, yeah, up, down, kneel. So you take someone who's on blood pressure medicine or heart medicine, that's keeping the heart rate and blood pressure kind of low, but that changing posture all the time, your body can't keep up. So they pass out, they're in the pew. We might have a hard time feeling blood pressure. We get there, and we land flat on the pew. Within a minute or two, they start waking up and start coming to. Just got them flat, allow their body to restore their blood pressure, and then hopefully things get better from that. Now, when you move into EMT, probably the next biggest treatment for heart failure that you'll be able to do is called CPAP. And that's, we start increasing those airway pressures in those air sacs, and that can actually physically start pushing that water out of the lungs from the inside out. Yeah, and so, yeah, this does not, she doesn't look like she has heart failure. But they get evidence of, and don't worry about the heart rate, stuff like that. Well, let's touch on the big stuff. So the sputum, again, we rarely see that, and that's just they're coughing up and it's bubbly, like a lung shot deer, kind of. Well, maybe not that bloody. Blood pressure, low, normal, high, rapid heart rate, they get real tachycardic at first, and then they start to get real bradycardic. So heart rate can be anywhere in there. Desire to sit upright. So you may be assessing a difficulty breathing, and an assessment we can ask them is, where do you sleep at night? And how do you sleep? How many pillows do you sleep? So to put it in perspective, there's a condition called paroxysmal, meaning comes and goes, nocturnal, at night, dyspnea. Paroxysmal, nocturnal, dyspnea. Someone who has heart failure is starting to develop heart failure when they lay flat. Now, with position and gravity, fluid starts to build up in their lung. They wake up, they can't breathe, they sit up, gravity pulls the fluids down, they can start breathing. So, you know, I've seen it where I've gone to a house and they're like, oh, I haven't slept in bed in 5 years, I gotta sleep in the recliner. Well, why do you sleep in the recliner? Well, because if I lay in bed, I wake up and I can't breathe. So we've got early stages heart failure, right, that they're progressing into it. So just questions that people at high risk for heart failure are the ones that tell you they're gonna want to sit up. They don't want to lay flat. In fact, if you try to lay them flat, they get real anxious and restless. Distended neck veins, I talked about that, kind of crackles or the wet lung sounds, obviously short of breath. Skin, when they're in heart failure, they get really sweaty, really pale. It can look a lot like a heart attack. And remember, a heart attack can cause acute heart failure. Abdominal distension, and that's just like, it's another form of edema, but they can get it in the belly. Elderly who are bedridden, we can actually see what's called sacral edema, which is very above the butt crack. There's a big puff of water there, tends to accumulate there sometimes, all just indicating that that heart isn't emptying enough. That's pretty extreme. There's some JVD. Everyone see that neck vein there? That's pretty good.
Jesus.
Okay. VADS, just to touch on that, you don't have to get too much in VADS. I haven't been notified. We should be notified as an EMS provider if we have an LVAD in our area. So what an LVAD is left ventricular assist device. People with really bad hearts may get sent home with essentially a machine that pumps their heart for them. Like if you feel a pulse on them, you might not feel a pulse. But they got this machine they carry, the batteries. So the EMS provider, we're typically noted, they give us their address, the type of, there's like 5 different VAD devices that are out there, so we get what their exact device is. If someone's got a ventricular assist device and you show up as a first responder, there's going to be first off, if they're not talking, you can do chest compressions on them. Generally, you shouldn't have to, but the big thing for the EMR is we get what their device name, and there's going to be a phone number on it. And the best thing you do is you grab your cell phone and you call that number and say, I've got a guy with a VAD, this is his device, and say right on there, HeartMate 3, and he's really like it. And they're going to talk you through some quick troubleshooting stuff, maybe, but there's not much. I think what I'm getting at is with ventricular assist devices, there's not much the EMR can do. There are certain things we have to do a little bit different on the ambulance. But yeah, I think as of right now, we don't have any in district that I'm aware of. I don't know about Lac La Flambeau. You guys know if you've got a,
I'm not knowledge, it's up ahead.
okay. Yeah, so like if we get notified, if like typical how it works is like UW-Madison would call me as the service director and say, hey, John Smith is a resident of Presque Isle, he's being discharged tomorrow, he's got a HeartMate 2 LVAD, we're sending you some information on it. And so then I immediately take that, collect it, and we send it out to all of our EMS staff, all of our EMRs, all of our departments, say, hey, this guy at this address has an LVAD, and if he's got complications, here's the steps. So, it's kinda, we don't need to dig too deep into it, but it's enough we should mention. So,
They all travel with backup battery packs also.
oh yeah,
Uh-huh.
let's see, you don't
Separate
administer
cooler.
nitroglycerin.
Batteries.
Did want to say, just kind of, I'm trying to see if it, thought there was a slide on here, the pediatric, I know, nope. That might be the next minute. Okay. Let's just try to take a 5-minute break, I'll go 30 more minutes, and then we'll cut you guys out. All right, so those were really, of the medical emergencies, cardiac and respiratory are probably the two big ones. These other things go pretty quick. So, we're basically gonna, the rest of the night here, we're gonna talk about altered mental status, strokes, and I think it includes headaches in here, which are good to talk about. So, causes of altered mental status. So the slides here, meaning altered mental status can be caused by structural disturbances. So structural, think anatomy issues, mass in the brain, burst blood vessel, toxic, metabolic, this could be infection, substances. So there's a lot of things that can affect how your meditation works, okay? On a small example, has anyone ever been awake for too long?
Yes.
Or you can't concentrate, you can't talk, so, like right now?
Yeah.
So, but it kind of affects your mental status, your ability to, so there's, it doesn't take much to kind of throw that mental status off.
No, I'm serious.
These are probably kind of the bigger causes. So shock, that when we have an injury or illness, that it's affecting our tissue perfusion. If we're not getting good blood and oxygen supplied to the brain, it's not going to function as well. Drugs, actually, and don't think of, I should say drugs don't have to necessarily be illicit substances. So this can very well be prescribed medication that someone intentionally or unintentionally took too much of. Could be that their home medication, they maybe been taking a little bit more than they should, and it's accumulated to toxic levels. Post-seizure state, we call it, with a generalized seizure, and we'll talk about seizures a little bit more in detail, but when they come out of a seizure, they'll go into what we call post-ictal phase, where they're almost unconscious for a little bit. It takes them a few minutes to start to wake up. It's kind of a slow process. Infections. Urinary tract infections, I think, are probably the biggest culprit for altered mental status, especially in the elderly.
Why is that primarily?
UTIs.
I would argue that that's
The
necessary.
infection.
She's asking about the process, like how does it go from too much back to front to altered mental status?
So ultimately, when you end up with an infection, right, it's localized, and as long as it remains localized, typically your body can handle that, you fight it off, and like, if you have those symptoms, but it will progress to the point where it becomes systemic, so that blood, like the infection goes from being in just that urinary tract area and migrates then into the blood, and then that infection becomes systemic and then leads to usually sepsis. And any infection infection can ultimately lead to sepsis, and it's just an overwhelming state, essentially, of infection in your body. Fast forward.
Yeah, I mean, what's hard about lecturing altered mental status is there's a lot of, I shouldn't say a lot. You know, what we do is we come in, ALS provider, or even a hospital, trying to figure out altered mental status takes time. Like a lot more time than what we can do in the field. So there's some, we're gonna check some big boxes right away. Checking the blood sugar is massive. That's kind of any altered mental status, blood sugar is key. We can test for it quick. It's a leading cause of altered mental status, you know, high or low blood sugar, and something that we can usually quickly correct, even at the EMR level. And you know, where every patient, and if I just forget saying this, that we're just gonna assume, you know, scene safety, BSI, examination, airway, breathing, and everything else. Okay, so obviously if we got an altered mental status and they're not breathing, we stop there. Like, we're not even 2 minutes. Fix the airway, breathing, circulation. But altered mental status can be traumatic, it can be medical, be it, you know, drugs, infection, a traumatic brain injury. There's a lot of things that can alter, and it's not super important to figure us out why. But look for clues, so, you know, we're asking questions like, when was the last time they were seen normal? You know, we usually can't get this from the patient. And I don't want to go too deep, but I do, it's something you're gonna run into. There's a term, and I think it's confabulation. So, an example of this, altered mental status, let's say you respond to a 65-year-old female, her sister called because her sister said she didn't seem right. I was here to visit her 3 days ago. She was sitting in that chair. And I came back today, 3 days later, she's still sitting in the chair, same clothes on, and she reeks of urine. So you can see in the chair that she's pretty much hasn't left the chair. She hasn't eaten, she hasn't gotten up, she's just been in the chair. So we start talking to her, and you know, what's her name? It's Jean. What's her last name? Smith. Hey, Jean Smith. What's going on? Oh, my leg hurts. Okay. How long have you been in the chair? Well, been in the chair today. Were you in the chair yesterday? Yeah, I was in the chair yesterday. Okay. Where do you go to the bathroom? Oh, I go to the bathroom. Okay, but why is your bowel and urine in the chair? Well, I can't go to the bathroom. Why? Because my leg's broke. Okay, when did you break your leg? Broke it last year. Okay, have you walked since you broke your leg? Oh, yeah. All right, but then why aren't you going to the bathroom now? Because my leg is broke. So, and I'm just giving you this example of the mental status. She knows who she is. She knows where she is. She knows when she is. But she can't put reality in with. So that's an altered mental status that's alert, oriented, but altered. Does that make sense? So I'm just trying to put that out there, that there's a lot of different variations. Now again, we, EMS, aren't gonna fix that whole problem, right? That needs much more diagnostics than what we can do. Collect medications, because just, you know, and I always ask patients, you know, you can make a mistake of saying, what medications are you on? First off, a lot of times you're not gonna know it. Medications are hard to pronounce. You can spend an hour just trying to write everything down. People will literally point to a box. A bunch of pill containers. Some are current, some are triplets, or triples of the same med. So you're going through, and this one's got half full, this one's almost empty, this one's newer than this one. It's just, it gets to be a lot. So a lot of people, you know, do you have a list? Where are your medications? Especially EMR level, EMS level, we're just gonna gather. And I'm gonna look at the meds when I'm going to the hospital, you know, to try to rough shoot, but, you know, we're not gonna figure that out, but to collect them, because medications can very much be a factor of altered mental status. We're gonna get a baseline set of vitals, which very well be normal. Altered mental status, we want to get a little bit more detailed head-to-toe assessment, because we may find, you know, a bruise behind the ear, on the back, or some trauma that may indicate this altered mental status might be due to that trauma. So good patient assessment, you know, respiratory rates, are their pupils unequal? Loss of bladder control. There's not much we can do for it other than check a blood sugar, and we'll talk about what do we do when the blood sugar is abnormal. When we talk about diabetes, not tonight, but that's probably the first and foremost thing. So if they're oxygenating well, they've got an airway, they're breathing, they got a pulse, a lot of it is just gathering information from them as much as we can. So beyond checking a blood sugar or addressing low oxygen levels, there's not much else we can do for altered mental status.
As an EMR, can you give somebody with like extremely low blood glucose, just like glucose tablets, or no?
Yes, EMRs can give oral glucose.
As long as they can follow commands.
This is the slide I was looking at before, just why they put it in here, pediatric assessment triangle. So when we're talking about kids, then kids are approached a little bit differently, but we can really simplify the pediatric assessment into what's called the PAT, pediatric assessment triangle. So the first thing I look at is appearance, and appearance is not so much how they look, but how is that kid interacting with it. So anyone who's been around a kid knows kids should have stranger danger for the most part. That you come in and if a pediatric patient seems a little fearful or cautious that a stranger is wanting to talk to them, that's normal. I like to see that. When I go to a house and a baby is, you know, I take baby from mom and baby starts screaming, that's good. That's what we expect that baby to do. But when you walk in and the child is listless or isn't even looking at us or tracking us as we come in the room, that's kind of a negative finding in that appearance scale. The next thing we look at is work of breathing, and it's normal or not. And so kids are, when they're using accessory muscles to breathe, it's very, you can visualize it very quickly. So if you see a kid having to really work or using extra muscles to breathe, that's just an indicator of respiratory distress, and we need to initiate some type of airway or oxygen therapy. And then the last part, appearance, work of breathing, is circulation, and we're looking at how is their heart perfusing. And the best thing we assess that is just capillary refill. Pushing down, getting it white, and letting go, it should pinken up in less than 2 seconds. So if we push it down and it takes more than 2 seconds for that color to come in, that is what we call a delayed capillary refill. And it's a good indicator of shock with the pediatric patient. And I'm kind of skipping over some of the specific to EMT curriculum. Dementia, delirium, just kind of briefly, it's not, dementia is a chronic progressive, and I just hate to use, because we're just going to say organic brain syndrome. So there's Alzheimer's dementia, there's different forms of it, right? So it can be everything from memory, mostly memory impairment, to some physical impairments, but those organic brain syndromes are progressive. That, again, you don't just wake up. So kind of like that emphysema, that there's a gradual worsening of symptoms. This we get from history, that I cannot think, and it would be exceedingly rare that we come across a patient with dementia without everyone else around. Now, I won't say rare. We actually had a call-in district last year for an altered mental status of a female at a campground. People started calling, going, hey, something's wrong with this lady. She's walking around, talking inappropriately. We met her, she's alert. She has no idea who she is, where she is. Physically, I mean, she can just walk 2 miles, and as we're trying to get what her name is, her husband, you know, I think you were husband showed up, you know, people, hey guys, she broke out of the cage. I shouldn't say that. But it's, you know, that can happen. And so that's very much when we have altered mental status, and we were really trying to get to a point where we didn't even get the ability to assess her yet. So those types of cases, everything slows down, we're gonna be here for a bit. She's not immediately in danger of clinical deterioration, but we can't just let her go. But dementia is slower, irreversible. Delirium, however, is a generic description for a bunch of other conditions that can cause an acute change in mental status. So there's several causes of delirium. It's very hard for us if I had a person with dementia and a person with delirium, we wouldn't be able to differentiate unless somebody told us that this has been progressive and this is their baseline status. So we just assume, unless we have a good outstanding history of dementia, that it's a delirium type issue, and again, it's check the blood sugar, the supportive care, and transport them to a hospital for more diagnosis.
So you would treat it the same, and so.
We would treat exactly the same.
Don't be surprised if there's like delusions and hallucinations too. I take care of an older lady, and I can tell the dementia is getting a little bit worse because her delusions are getting stronger, and then hallucinations too. Like she'll tell me that she sees cars outside and they're in the middle of nowhere and there's no cars. You know, it's a little scary, but.
So with stroke, and I'll try to finish up with kind of watching, because I made a promise I might stick with it. Strokes are similar to heart attacks, except it's in the brain. So it's a disruption of blood flow to a portion of the brain. And really two primary causes. It can be hemorrhagic and non-hemorrhagic. So a hemorrhagic stroke means a blood vessel burst, and there's bleeding in the brain. So the blood flow is interrupted because the blood going down the pipe coming out of a leak. So it's multiple problems that brain tissue isn't getting blood because blood's leaking. And inside your skull, it can't swell. So as pressure builds up, it can't swell your head. It pushes brain and everything inward. So we start to get structural displacement of brain tissue. And some of the bleeding can be severe enough where it starts to permeate the brain. So the spinal cord comes up through the base of your skull, it's your brain stem, and then your brain. So there's an opening at the base of your skull. That pressure can get bad enough that it starts to actually push your brain through that opening. That's called brain drainage. Nothing we can fix. The other case of a stroke would be an embolotic stroke or an actual blockage. So chunk of fat, you get the same process. Chunk of fat, like an embolism gets wedged in there. Blood clot breaks loose from somewhere in your body and makes it up in there and makes a blockage. There's good news that there is some redundancy in the blood supply of the brain, but I'm trying to think how we can do a stroke scale. So Katie, and I'll kind of lean on you. What's the in vogue stroke scale now?
Be fast.
Okay, so
And if you want to add a be fast or, but they add the arm.
any altered mental status, in addition to blood sugar, we want to do a stroke assessment. Katie, would you do a stroke assessment on me?
I'm going to combine all mine.
Hmm?
I'm going to combine all mine.
So kind of talk through what you're checking as you do.
So when the first thing that you want to recognize is time is tissue. And so recognizing a stroke, they used to call it the golden hour, and now it's like a little bit longer than that. You have up to 6 hours. But there's multiple pathways in the brain called circle Willis that is able to oxygenate your brain, and that clot is blocking it, so it's only getting the the blood flow and the oxygenation from one way when there's a clot there. So you want to open that back up so that they can hopefully regain some function. And a lot of times stroke survivors do really well if we get them to definitive care quickly, and they can either use the clot busters or they're able to get them into a neurosurgeon if that's what they ultimately need. So first thing is being fast, and that's part of the be fast scale. So there's a lot of different methods that we use to do stroke scales. There was the Cincinnati, there was an LA, and they were just based on like the different places that you can do it. So a lot of times I kind of combine all of mine. So right away I'm gonna talk to the person, be like, Jason, can you hear me, right? And I'm gonna like watch his eyes, and if they track, right, that is one of the things I'm looking at. Or if one is like drifting away, or you'll see oftentimes if somebody's having that hemorrhagic stroke or there's a spot in the brain, they're gonna look to where that stroke is actually happening. So their eyes will go up and towards where the injury is. So looking at their eyes is gonna be a really good indicator. So I'm just gonna look straight at him, and I'm gonna, can you see my finger here? Just try and follow that. And like, if he's having that stroke, that they're just not gonna track, right? He's gonna keep looking up towards where that injury is. So that's the E in DFAST. A lot of times, balance is gonna be your other one, right? If they tell you, I fell, I'm stumbling, right? That's your first B. If he has already had that, I'm not gonna ask him to stand up and do those things. So I'm gonna combine some of these other ones. So if you ever watch me do a stroke scale as I'm doing this, all right, Jason, my name's Katie, I'm a paramedic. I'm just gonna have you do a couple things for me real fast. I want you to put your arms out in front of you. Go ahead, and I'm gonna help you hold them up. I'm gonna have you close your eyes, and I don't want you to drop your arms. I want you to hold them. I'm gonna move my hands, you keep them there. And I'm gonna let him go. And if that arm drifts down, that's indicative that he's got that one-sided weakness. If he's able to hold one and the other one drifts. Usually that's gonna happen right away. So that's the arms. I'm gonna have him then grab my hands, and I want you to squeeze my hands as tight as you can at the same time. Squeeze, 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 squeeze. And what's gonna happen is you're gonna feel there's either gonna be a difference on the right or left as to whether or not one is stronger than the other. And typically, a lot of times, I do my assessments kind of from this position in front of them, because then right away I can reach down to his toes, and I'm saying, pull both of your toes to your nose. Pull them up, 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 up. And then he can either do that or not. And then if there's weakness or not, I'm then gonna immediately put my fingers underneath his feet, and I'm gonna say, push him down like a gas pedal, both at the same time. Push, 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 push. It's fine, I'll wash my hands. So, and then, so you want him to push down on your hand, so it's that up and that down, right? And so right away, I'm looking for that equal strength, and I'm looking for that on all of the extremities of the body, right? Because typically, if you have a stroke, depending on where it is in either the brain, or if it's somewhere in the brain stem, or you can have some impairments too in the spinal column. Depending on where that is, it's going to tell you where the injury is in the brain, right? So typically, if it's on the right side of my brain, I'm going to have left-sided weakness and deficits, and it's going to be opposite, right? Because our brain actually crosses as it comes through the body from the brain and goes down into the body. So you'll see those deficits. I'm also going to do a couple things as far as looking at his face, right? And so you're looking for, and that's the F in DFAST, is face. So B is balance, right? Can they walk? Are they losing their balance? Anything like that. Eyes is your E. Fast is face. So I'm looking at their face, and a lot of times what you're gonna see is you're gonna ask them to smile. I want you to smile real big, and I want you to smile with your teeth. Smile, 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 smile. And he's faking it right now real well, right? You'll see one side of their face go up, and the other side go down. And that is indicative that there's weakness in the facial muscles. There's a false positive that you can get if there's Bell's palsy, not something that you guys need to know. If you see these symptoms and you're concerned, until proven otherwise, it's a stroke. So face, the arms is the one I already showed you guys. And then S is gonna be for speech. So you're gonna ask them to say a phrase. So Jason, I want you to repeat after me. You can't teach an old dog new tricks. And that's what you're gonna hear. He's gonna have that inability to speak, and they're gonna, like, their words are gonna be kind of droopy, or they're gonna say things where I'm gonna say you can't teach an old dog new tricks, and he's gonna go cat, apple, blue, and he's gonna have this word salad that comes out, because depending on the part of the brain, if it's in like the Broca's area of your brain, he's gonna have that speech impediment. He's not gonna be able to get out what he wants to say the right way. If he doesn't understand what I'm asking him, it's probably in the Wernicke's area. And so like you can figure out different spots in the brain. Again, I'm telling you stuff based on like higher level training. You don't need to know like all the different areas of the brain. but based on their responses, if you're seeing these things, it's stroke worthy until I get proven otherwise. And then the T is your time, right? So you want to get to them, and that's why that question of when was their last known well time? Because if this was, well, they went to bed at 10 o'clock last night and they were fine, and now it's 9 o'clock in the morning, we're outside of that window to get them to our nearest. They're still going to a CT scan, but they may not qualify for thrombolytics, they may not qualify for some other treatment measures, and then it's gonna be more supportive care and see where things go. But if we know, they were fine until like, he was talking to me and he was fine, he was just sitting here, and then all of a sudden, like 10 minutes ago, he just started acting really funny and he wasn't himself. That's within that golden hour, and we have that ability to respond. And so the fast area is respond. We want that response. You want to call for help. You don't want to be like, oh, you know what, go lay down and take a nap. Maybe you'll feel better. No, you want to call immediately. That response is super important because if you don't, you're not going to get them to the hospital on time.
And stroke scales are, we're gonna practice them Saturday. Thank you, Katie. Stroke scales are kind of altered mental status. I'm adding glucose, stroke scale to everyone. And it's, the balance, you know, I'm not gonna ask them to walk, but balance is specifically checking on what's called a posterior stroke. So, you know, you got a normal looking brain and there's kind of a ball on the backside called the cerebellum. And cerebellum is coordination, movement, upright, that. If the stroke is back there, I can have equal strength, arms work, I can smile normally, speech is good, but my balance, I get rapid onset vertigo.
They're stumbling, they run into things,
Yeah,
they just don't have
I can't control my balance. Even my father-in-law, 2 years ago, had a posterior stroke, and what he described it, he said it looked like the room was upside down, like all you guys would be sitting on the ceiling. And when the doctor came in the room, he said it, you know, that you could see the doctor walking, so it's just, it distorts anything to do with your spatial orientation. So, you know, and I'll even go, someone says they have a new onset vertigo. For me, as an EMS provider, that's a new onset stroke until proven otherwise. So, you know, we're gonna move kind of quickly to get, you know, they've got to get to the hospital. But if it's the cerebrum part of the brain, that's what we're checking, the facial symmetry, the speech, and the arm strength. A stroke scale takes less than a minute. You know, this is something we're progressing through real quick, but like Katie said, the most important thing question we can ask or try to ascertain is the last known well time. That whole stroke scale, that's really typical of the clot type stroke. The hemorrhagic strokes, classic presentation is someone will have the worst headache of their life, followed by rapid deterioration in their level of responsiveness to the point of being unconscious. And by rapid, I mean they can go from worst headache of my life to agonal breathing within a few minutes. So
And in your book, you're gonna get a test question on this, it's a common one. What is the name of that headache? It is a thunderclap headache.
Thunderclap, that was my secondary nickname.
These are-
Anyways, okay, I think that's, told you guys that we wrapped up, so we'll call it. Saturday, we're gonna focus on hands-on, then we're gonna finish up medical in the following week and slide into